Okay, so Assalamu alaikum everyone. My name is Abdalla Mohamed. I'm a second year medical student, and with me here is
Ahmed Masoud, also a second year medical student.
today we're excited to give you the cardiology practice questions, pal, for this upcoming CVP exam, inshallah.
Inshallah. Here's our contact information on the first slide and on the last slide. Feel free to approach us, contact us, whatever, whenever you have any question. Inshallah, we'll be able to help you. Yeah, so I will be starting now. First of all, we are gonna have two objectives in the video lectures. Then we're gonna have a general exam for you guys, test your knowledge. Okay, first question. Is there a volunteer that would like to read? Maybe. Okay, no problem. I will read. So the sinoatrial node initiates the cardiac impulse at 0.00 seconds. The action potential then travels through the atria, uh, then to the atrioventricular node, and then his Purkinje system. At what time will the action potential normally reach the Purkinje fibers? So please type your answers on the chat. C, okay. So whoever said C, you are correct, and I will explain why now. So it is serious. That's correct. Now, this is straight up from your lectures. Okay. So zero point 0.3 takes 0.3 seconds from the SA node to depolarize all the atria, then to the AV node. Then at the AV node, there is an AV nodal pause to give the chance to the ventricles to fill up, which is approximately 0.09 seconds. So that will be a total of 0.12. Then from the bundle of His to the Purkinje fibers, another 0.04 seconds. So this was a recall question, but why did I add it? Because the doctor emphasized on it a lot. He kept mentioning on and on in the lectures. So I'm guessing that there is a chance that he'd get a question from here. Okay, so our next question. In the SA node action potential, which channel is responsible for the resting membrane potential? Isn't 16 seconds to reach the septum, not the Purkinje fiber? No, it's 16 seconds to reach the Purkinje fiber, as you can see here. We're taking the AV bundle. Okay, so it's to reach the AV node, then to continue to Purkinje fibers. Okay. So whoever said D, you are correct. So let's rule out the choices. Decrease. So in a resting membrane, who can remind me how does the resting membrane in the SA node looks like? Is it straight or is it inclining up? Inclining up. Yeah, that is correct. So you'd normally have to have positive ions coming inside the cell. So decrease conductance in the calcium channels, both of them would be wrong. So we can rule out A and B. Increasing to fast Na channels. Who can tell me does that exist? Does it exist in the SA node or where does it exist exactly? That's straight. Okay. In ventricular myosite. Perfect. Perfect. MashaAllah. Yes, that is correct. So we can also rule out C. So to leave us with the E and D. And increased conductance through calcium through potassium channel. Now, potassium channel, is it influx or efflux? It's efflux. So that would make the cell negative. So D will be the only correct answer. And I showed this graph again because he mentioned the importance of this graph a lot in the lecture. Again, I would guess a question would come from here. I would recommend knowing the differences between ventricular muscle fiber and the SA node with the channels of each step. Okay, so now we're done with the first lecture. Let's go to the second one. When measuring isotonic contractions in a cardiac muscle preparation, increasing the length of preparation beyond the resting length, L0 prior to electrical stimulation would produce which of the following changes to active and passive tension? Okay, so the answer is D. So let's get to the explanation. So I found this picture right here that would makes all the explanation in the question. So right here is the optimal or the L0. So increasing the sarcomere length, let's back to the question. So increasing the length of the sarcomere length beyond this would sorry, would decrease the active tension because now you have them overlapping and some of the myosin won't be able to bind to the actin, and the passive tension would increase because the titin is now more stretched, so now you have basically more pressure, more tension. Okay. So before we get to the next question, does everyone understands all the previous questions, right? No confusion. If there's any confusion, please stop me at any time and ask me. Okay, so I'm guessing no confusion, alhamdulillah. So, Bismillah, excitation and contraction coupling is a process in which muscle cell is stimulated to contract. And this process is followed by muscle cell relaxation. It involves the following events. Action potential, calcium release, cross-bridging cycle, cytoplasmic calcium removal, the polarization of T tubules. Which of the following lists correct sequence of events for excitation, contraction coupling, and skeletal muscle? Can you repeat the previous question? Do you mean this question? Yes, okay. So here it's talking about when when it comes like this, like you have the actin and myosin. So when there's overlapping, some of it like not every actin has one myosin. Some of them won't be able to bind the actin and myosin. Now I'm sure I have some other figures. Now if you text me on WhatsApp, inshallah, after the session, I have better figures to explain the confusion, and inshallah, just remind me on WhatsApp. Okay. So let's get back to this question. So what were the answers again? Good. Yes. Favorite set B, yes, you are correct, mashallah. So, Bismillah, let's explain. So first, so I have this, I got it from ChatGPT, which is what, again, I don't really like to rely on ChatGPT, so let me draw it out for you. So, Bismillah, yes, okay. So let's say you got this cell right here, okay? Well, actually, better let's write the cell like this with the invagination. Just then with a nerve to stimulate it, okay? So when it's nerve stimulated to produce action potential, which side will be positive, which side will make negative? Is the outside negative or the inside positive? The inside will become positive, okay? So let's see. Let's say we have action potential all around the cell, so negative, 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 and positive. So the action potential will go all around the cell until it reaches the invagination, okay? So as seen here, so first of all, there's action potential, then then the stabilization of T tubules, or the invagination. After that, we have two, which is calcium release. Okay. So after the tubules are depolarized, they will open some channels in the endoplasmic reticulum, which will release calcium. After calcium is released, it will bind to the myosin and so on. Okay, and then the cross bridging happens. After the cross bridging cycle, the there will be removal of calcium. Okay, does that make sense? Okay, so bismillah. So now we're done with lecture two. Let's get to ECG one. During a routine ECG recording, clinician observes the presence of a distinct P wave before each QRS complex. This deflection occurs just prior to the onset of ventricular depolarization and is an important indicator of normal silence to rhythm. Which of the following events of the cardiac cycle does the P wave represent? So, okay. So as you can see, I tried like a lot of doctors try to trick you with a lot of words in the paragraph. Like you can see here, three completely useless sentences. Like you don't get anything. You can just read the last one. Which of the following events of the cardiac cycle does the period represent? And you all answered correct, mashallah. Everyone answered B. Bismillah, mashallah. Okay. So this question is clear, right? But again, I just have this is the summary of what each wave represents on the ECG. We have depolarization. Sorry, there is typo here. The PR segment is the AV nodal delay. QRS is the ventricular depolarization, and then TUF is repolarization here. It should be repolarization. Again, another typo. Sorry about that. So here I have a link to a video. We're not gonna watch it now, but I recommend watching it. It's really good. It's just a 3-minute video showing the electrical impulse through the heart alongside the ECG. So, Bismillah, the next question. Which of the provided images correctly labeled for the electrode placement and polarity of the three standard limb leads? Limb leads. B. Okay. MashaAllah, MashaAllah. So that is correct. Exactly, B. So here's again every lead. So we got on the right arm, we got both negative. So you got here, first of all, negative, then positive, then negative, and then your left leg positive. And then third lead, you got negative on your left arm and then positive on your left leg. Okay? Does that make sense? Next question. Okay. Bismillah. So for the attached ECG trace, what is the most likely condition affecting this patient? E, C, C. Okay. So let's solve it together. Bismillah. First of all, can you see any elongation of the PR segment anywhere? No, you cannot. Okay. Is the P to QRS ratio 1 to 1? Yes, it is. So you can rule out type 1 because they're in type 1. Sorry, you can rule out both second degrees because it's 1 to 1 ratio. And you can rule out first degree heart block because there would be PR elongation. And then atrial fibrillation, it looks very weird, does not look like that. So whoever said C, sinus tachycardia, yes, you are right. Because here you can clearly tell there is only two large squares, which indicates almost 150, the heart rate. It's normal fast, yeah, perfect. It is normal. Yes, exactly. So the answer is C. So the next question. A 60-year-old man weighing 220 pounds had the following ECG, which shows the standard led to. What is his diagnosis? So, well, yes, the third, yes, exactly. It is the because you can tell the third degree is like very special. You can tell a lot. There is a lot of P's with not a single small QRS wave. And why does that happen? Can I already explain why does that happen? You got a lot of P's with no QRS. Block of AV node. Yeah, exactly. So the SA node will be going at its own rhythm, and the Purkinje fiber will be giving the QRS. And there is no like electric impulse going from the SA node to the Purkinje fiber. So each one will be at its own rate. So I'll be summarizing the type of blocks here. So you got, I believe the doctor mentioned 5 types of blocks. First type was SA node block. So if your SA node is blocked, you have no atrial depolarization. And what we said, which one we said about the what did we say about the atrial depolarization? It represents the P wave. So normally there would be no P wave, or it would be inverted. But I believe the doctor mentioned only no P wave. And then for the 3 degrees or the 4 types of AV node blocks, you got the first degree, which is just barely any blockage. There will be only elongation of the PR segment. Then the second degree, you got 2 types. First of all, one of them for the first one, type 1, which is Mobitz type 1, I believe, you got the PR segment keeps on elongating until there's a drop in the QRS wave. And then type 2, there is a bit extreme blockage, which will find random drops of QRS. And then third type, we mentioned it here, a lot of P waves and the Purkinje fibers alone. Okay, that clear? Is there a PDF for this session? Yes, we will be sending out this for the slides, inshallah. Okay, 25-year-old healthy patient suddenly develops rapid palpitations. ECG shows normal QRS complex with no visible P waves. What is the most likely condition? MashaAllah, you guys are perfect, MashaAllah. It is B. Yes, that is correct. So for ECG3, I noticed something about the lecture. It's all about arrhythmias. You could study it 2 ways. You could either memorize you can either memorize what are the ECG, like how does it look with each one, or you could understand what does paroxysmal tachycardia means. So here you can just memorize the okay rapid palpitation. Here you can see that it's tachycardia. It's tachycardia, really high heart rate, and then normal QRS complex, almost normal, okay. Then no visible P waves here, total missing or obscured P waves. So if you just memorize what the doctor said, you could have answered this question. Okay, so the next question. A patient's ECG shows an early heartbeat with no preceding P wave, a wide QRS complex, and a T wave that is opposing in polarity to the QRS. What is the most likely diagnosis? Yes, you all got it correct. It is C. That is correct. So I just showed how you could memorize. Now I'll explain how you could understand. What does the word preceding P wave? Sorry, what is the what's premature ventricular contraction? So it's just a ventricular contraction that happens out of nowhere. Okay. So it happens out of nowhere. There would be no P wave for it. It just happens. There is no P wave for it. And because it happens, there would be a pause, like to get the heart to restart after it. So, and yeah, I guess if you understood all of that, you could answer this question too. Topic pacemaker. Yeah, yeah, before it's time. Perfect. Yeah, you guys are correct. Okay, so this was mentioned in your P15 interactive session. I think it's important. I believe we got a question about it last year. So I just quickly put a summary for it. I got this graph from last year's slides. So the normal axis would be between -30 to +90. Okay. And then first of all, what does the axis mean? What does like axis of the heart mean? Can anybody answer that, please? How do you know it's not an inverted? How do you know that it's not inverted? I don't understand your question, Mariam. Wait, let me get back. Yeah, the way the vector of depolarization. I mean, you're both correct at the same time, but not the perfect. I mean, not the perfect definition. The axis of the heart means the mean electrical impulse. So if you added all the impulses together, which way would they direct? So that the way of signal moves makes sense. The first technology, the period is after. Yeah, what about that? Okay, it is after it's key. I really don't understand the question. I'm sorry. Can you just put it more clearly, please? Circle. Hmm. It is a T wave. It's not a P wave, and it's a T wave because it's the way that the ventricles repolarize, and because it's premature, the first thing that depolarizes would be the first thing to. Sorry, I mixed up something about that. Well, follow up on that question more, and I will on WhatsApp, and I will answer you. I promise. But right now, I'm not sure what you mean, and we got a time to stick to. Oh yeah. So again, the axis. So the if you add all of the impulses and you put them in one direction, it should be from -90 to positive. So it's -30 to +90. And a fun way that I found out, Dr. Put it, it's if it's a left axis deviation, you'll find on lead one positive, lead one because it's like this. So here we have a positive lead one because it's within the range, and then a positive lead two because it's here also within the range. You'll also have it positive, and then a negative lead three. As you can see, here is the lead three. So if it is if it's negative two, if it's also negative, that means it's definitely outside and mean electric would be almost like this, and that's not normal, and that's left axis deviation. So yeah, left axis deviation. Yeah, it will be completely negative. Yeah, I mean, sorry, I mixed something up. Sorry. Scratch whatever I said. Left axis deviation. If it's third lead is negative, that means it's pointing this way. So that confirms the diagnosis that it's a left axis deviation. And for the right axis deviation, if you have both of them negative, it will be pointing almost here, okay, the first lead. And then the second lead, it will be, if it's negative also, that would definitely confirm because it would be around here. And if the third one is positive, that means it's also around here. Okay. So I mean, I guess you could summarize it in a way that you could think about it like logically. If you combine all of them, like lead one, lead two, lead three, you could approximately guess where's the mean axis deviation. Okay, so that is it for my part. Not I mean it's Abdullah's part now. So I'll be leaving you with.
Yes, Assalamu alaikum everyone. This is Abdullah here. We're going to be starting with the cardiac cycle as my first lecture. Tamam. If you have any questions, please feel free to stop me at any time. So this is the first question. A diagram showing pressure changes of the left atrium, left ventricle, and aorta, and they're labeled LA, LV, and A. During one cardiac cycle is shown. The 7 phases of the cardiac cycle are labeled on the diagram 1 to 7. During which phase of the cardiac cycle is the largest volume of blood pumped from the left atrium to the left ventricle? I want to see the answers in the chat box. F6, yes. So, okay, let's see the answer. MashaAllah alaikum. As you guys said, the answer is indeed F. So the way to approach this question, or the way to approach cardiac cycle questions in general, is that you should firstly start by having a specific point in the graph that you always refer to, طيب? Because it's basically a cycle. For wherever you start, you're going to end up doing the same thing. And personally, I love looking at this peak right here in the beginning, because it's the easiest to detect aslan. And you could tell this is the left ventricle contracting, the pressure is going up. So this is the first thing that you should look for. After that, the question is saying إنه this is the key point in the question, that the largest volume of blood being pumped from the left atrium to the left ventricles. And in order for the blood to move from the left atrium to the left ventricle, what must happen? The AV valve must be open. And for the AV valve, the mitral valve specifically, to be open, the pressure in the left atrium must be higher than the pressure in the left ventricle. So you look at the graph and look at the phases in which the left atrium pressure is higher than the left ventricle. So we're talking about 0.1, 0.67, okay? When you look at 0.1, okay, uh, oh, let's look at the peak again, sorry. After that, we have these two phases. The peak signifies the ventricular contraction, صح? Following that, at this point, 0.5, this is when the left atrial pressure first exceeds the left ventricular pressure. And when that happens, imagine, the mitral valve is closed. It's just filling up with blood, filling up with blood, filling up with blood. As soon as it open, due to the increase in the pressure that resulted in the left atrial pressure being higher than the left ventricle, as soon as it open, the blood is going to start rushing rapidly inside. And that's when most of the blood is going to move into the left ventricle. That's why the answer is F. In phase 1, as you can see, it's basically the same as this point after phase 7. And it's basically when the atria is contracting. We have atrial systole to push the remaining blood. That's why the answer wouldn't be A. That's basically the remaining 20% of the blood that's being pushed in. Okay. So here's the cardiac cycle. Let's quickly go through it. Let's start from the bottom. Phonocardiogram. Phono, if I'm not mistaken, in Greek means sound, I think, or voice, something like that. But this is basically about the heart sounds. S1, S2, the are really too important for this lecture. The ECG, you guys are familiar with it. And then the rest of these are what's important in the cardiac cycle lecture. But as we said, it's a cycle. So wherever you start is the same. Let's look at the peak. And this peak, it's when we have the ejection. طيب. This peak is generally split into two, rapid ejection and then slow ventricular ejection. Let's start with this point. طيب. The point in which the pressure طبعا هنا is the labeling, ventricular pressure, atrial pressure, and so on. So at this point, when the red graph exceeds the dotted graph, we've got the AV valve closure. طيب, let's say the mitral valve closed, and the pressure is now higher in the ventricle. After that, the ventricle is going to contract, and the ejection starts. Now, when it's contracting, initially we've got isovolumetric contraction. And why is that? Because the pressure in the aorta is higher than the pressure in the left ventricle. So the aortic valve is still closed, but at the same time, the AV valve is closed. So the ventricle is contracting, but both of the valves that correspond to the ventricle are closed. So the blood has nowhere to go, basically. That's why it's isovolumetric contraction. Contraction is taking place, but the volume is remaining the same. Tamam? And if you look at the volume here, it's not changing. So the pressure builds up, builds up, builds up. As soon as it exceeds the aortic pressure, the aortic valve is going to open and the blood is going to be rapidly pumped outside of the heart into the aorta to be carried into systemic circulation. Initially, it's rapid. After that, it starts slowing down. And then at this point here, the aortic valve, the pressure in the aortic valve exceeds the pressure in the left ventricle. And as a result, what happens? The aortic valve closes to prevent the blood from flowing back into the left ventricle. Tamam? So as a result, we enter another phase, which is isovolumetric relaxation. Again, the AV valve is still closed, the mitral valve, or the aortic valve up here is also closed. The ventricle is relaxing, but there is no any blood flowing into it. That's why the volume again remains constant, isovolumetric relaxation. When we get to this point specifically, the pressure, as you can see, the dotted line, the atrial pressure exceeds the ventricular pressure. And when that happens, the mitral valve opens. Tamam? When the mitral valve opens, remember what we said, this is the answer to the question. The blood starts rushing rapidly into the left ventricle. As a result, this phase is known as the rapid inflow phase. After that, it starts to slow down a bit. We get the diastasis. So this is the second phase of ventricular filling. After that, we've got atrial systole. And if you could look at the ECG here, this is an important thing to keep in mind. The electrical action always precedes the mechanical action. And the P wave, which is responsible for the atrial systole, is followed by the atrial contraction. Tamam? And we need to see the electrical impulses move in the ECG first in order for the mechanical action to take place. So here, the atrial systole takes place and pushes the remaining 20% of the blood into the left ventricle, and the cycle basically repeats itself. Let's move on to the next question. Can you please answer in the chat box? Okay, seeing a couple of these. Okay, mashallah alaikum. So as you guys said, the answer is indeed B. Let's read the question. The figure represents the pressure changes in the jugular vein during a single cardiac cycle. Which event produces the C wave on the jugular venous pulse waveform? Tamam. Our options, right atrial contraction, bulging of the tricuspid valve, slow filling phase of the ventricle, opening of the tricuspid valve, and rapid ejection of blood from the ventricle. As you guys said, the answer is B. And let's look at this explanation. We've got three things that I want you guys to focus on, the A, the C, and the V. The question specifically asks for C. Let's start with it. Dr. Mooney said in the slides that the C wave comes after ventricular contraction, but our answer here says bulging of the tricuspid valve. So to simply explain it for you, if you look at the ECG here, this phase is atrial systole, as we said. It's when the atria contracts or pushes the remaining blood into the ventricle. So at this point, the AV valve is open, the mitral valve, and the blood is flowing into the ventricle, صح? Now, this volume is building up, it's building up, it's building up in the ventricle. Eventually, the ventricle command itself is going to contract. When the ventricle first contracts, this AV valve is still open. And initially, the pressure in the atrium was higher than the pressure in the ventricle. So when the ventricle begins contracting, the pressure increases in the ventricle, as you could see over here, and it starts preceding the pressure in the atria. When that happens, the valves are forced shut. When the valves are forced shut due to the high pressure, it doesn't just shut, but it even bulges back into the left atrium. So as a result, it's responsible for the C wave that we see on the cardiac cycle. Now the V wave comes from the end of ventricular contraction. It's basically the blood that's flowing into the AV valve. Because remember, at the end of the ventricular contraction, the AV valve is still closed. فخلاص, now the heart is entering diastole, it's starting to relax, and the blood is passively flowing into the atria. The valve is closed, so when the blood starts building up on the valve, it's responsible for the V wave. And the A wave comes from atrial contraction. Now, PV loops. The image shown is a left ventricular PV volume loop, pressure volume loop. Which of the following points MNOP correctly describes when diastole begins, when systole begins, when the aortic valve opens, when the mitral valve opens, and when the mitral valve closes, respectively? Ahmed, so but can you answer my question? Which one? The question is about the wording pumped. Okay, so I just saw this now. I have a question. It's about wording pumped. Is it supposed to be normal? Like we know it's stage 6. I guess you're talking about the cardiac cycle question. Let's go back to it quickly. This one. What does the question say again? معلش. We know in stage 6 fills most of the ventricle blood volume, but it's by rapid inflow, not by pump, because the atrium still did not contract, right? Yes, as you said, Fuad. Initially in phase 6, the valve were closed, تمام? As you can see here. The pressure in the ventricle, oh, let's take phase 5. The pressure in the ventricle was higher than the pressure in the atrium, for the valve is now closed. As soon as the pressure in the atrium exceeds the pressure in the ventricle, the valve is going to rapidly open, and all of the blood that was kept behind the valve is going to rapidly move in. And let's say, for example, back in the day in grade 4, طيب, when we used to have PE, and the teacher would be closing the door waiting for us outside. As soon as the bell rings and they open the door, all of us start rushing out to go to the playground. It's basically the same thing. Think of it that way. As soon as you open it, it starts moving in rapidly. You're correct. There is no pumping taking place neither in phase 6 or in phase 7. Both of these take place passively. تمام. But here, when we look at this part, phase 1 basically, لأنه again, it's a cycle. At the end of 7, and the end of 6, 7, again, we'll get 1 here again. But 1, this comes from the contraction of the atrium, which comes after the atrial systole, تمام? Well, this is responsible for 20% of the blood. And the majority of the blood comes in passively. The remaining 20% is the part that comes in actively and is pumped, as you said. All clear? Of course. Let's get back to our question. PV loops. You guys said A. ما شاء الله عليكم. يعني مبدعين this session. Now, PV loops is one of my favorite topics in CVP صراحة. It's a really fun topic. It's all about understanding the graph. طيب. When we're moving from point M to point P, I want you guys to focus on the axes. When we're moving from M to P, across the x-axis, we have an increase in the volume, تمام? So the volume is going up, but the pressure not so much. يعني نحن, if you want to increase the pressure, we'll move up in the y-axis. If you want to increase the volume, we'll move horizontally in the x-axis, تمام? So moving from this point to this point, and from M to P, the volume is increasing rapidly. It's going from 50 to 120. However, the pressure basically remains almost the same. That's why فيا I want you guys to focus on this part لأنه شنو there is no contraction taking place here تمام. That's why the pressure remains almost the same. This is all passive. This برضه corresponds to the point that we're talking about earlier in the graph. The 6 section, بعدين this is the 7. Here, there's a slight increase in pressure. This part results from the atrial contraction. تمام. Let's look at the question now. طيب, diastole begins at point O. I think it would be better to explain it here on this graph. تمام. The way to approach PV loops is that start by looking at this point. As we said, when you're moving this way, there's an increase in volume. When you're moving this way, there's an increase in pressure. But moving from point A to point B, the volume is increasing significantly with a slight increase in pressure. This corresponds to شنو? This is the point at which the mitral valve is going to open. I believe this was one of the points of the question. Yes, this is the point at which the mitral valve is going to open. Let's approach the question. Like now we know that point M is the point at which the mitral valve opens. And at this point, the pressure in the atrium exceeds the pressure in the ventricle. And as a result, the mitral valve opens or the blood starts flowing in rapidly. Looking at the question, it's only option A, B, and D that are saying in M is the point in which the mitral valve opens. After that, the volume is increasing until we get to this point. When we're looking at point P, between point P and N, there's an increase in pressure, but the volume remains the same. So what does this mean? The ventricle is contracting while there is no blood movement. If there's no blood movement, this means that the aortic valve up there is closed, with the mitral valve is also closed, which means that at point P, it's when the mitral valve closes. But looking at the options that we have again, we're only left with option A that corresponds to this. We have option A and option D as well. But then let's move on and look at one of the other factors, the aortic valve opening. So here we said this was isovolumetric contraction because the pressure is going up while the volume is remaining the same. Iso means same, so isovolumetric, same volume while the pressure is going up. Moving on from point N to point O, what is happening? We've got a decrease in volume. So this means that the aortic valve opened, point N, and the ventricle is now ejecting the blood rapidly from the ventricle to the aortic to the aorta. تمام. As a result, this is the rapid ejection phase. We could see the volume is going down, or the pressure is going up because the ventricle is contracting. Eventually, this is the slow ejection phase. After that, when we get to point O, notice the pressure again. The pressure is going down while the volume remains the same. So what does this mean? This means that the mitral valve, it's still closed as we mentioned earlier, but this means now the pressure in the aortic valve exceeded the pressure in the left ventricle, causing the valve to close. As soon as the valve closes, now both of them are closed. So as a result, diastole begins, or relaxing, with the volume remains the same, the pressure is going down. That's why it's diastole, or that's why it's isovolumetric. Looking at the options, we're left with option A. But that's the beauty of these questions. And حتى if you're not sure مثلا is it A or D, you could still have a better guess compared to the other options because you could eliminate many of them just by knowing a thing or two. Check the chat. What's the extent of diastole in the graph? Diastole starts from isovolumetric relaxation. Yes, this is the point at which diastole is taking place. What's the extent of diastole in the graph? I don't understand your question, honestly. Diastole is from point D until I would say A. لأنه following actually you're right until almost B. لأنه A going this way, this is all برضو as we said earlier. The filling is done passively. But towards the end of P, this is when there's the slight atrial systolic contraction taking place. So I guess you're right. You could say no, diastole is from this point, from point D, all the way to this point, before the small tilt, the small rise in the graph. Does that make sense? So A to B is not fully diastole, but I could say, let's say 80% of it is diastole. And up until this point, up until the pressure or the volume, sorry, of 110. تمام. And preload and afterload, I just wanted to explain this quickly. The way I want you guys to think of preload, it's the maximum amount of volume that the ventricles could hold before contracting, تمام? So it's basically measuring the stretch in the muscle. When you're filling up the ventricle with blood, it's stretching, 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 stretching. This is preload. The maximum amount that the ventricle could stretch is the preload. The afterload, think of it like a wall, تمام? It's the pressure that we need to overcome in order to push the blood out of the heart. It's basically the pressure in the aorta, تمام? Because remember, the ventricle's pressure needs to extend above the aortic pressure in order for it to release the blood to the rest of the body. So an important factor to keep in mind is that the afterload is a pressure while the preload is a volume. And they could easily trick you with a simple MCQ and which of this is true about preload. One of the options would be it represents اسمه شو ده? A pressure value or a volume value, and the answer would be a volume value. Make sense? Okay, PV loops. A 60-year-old woman has a resting heart rate of 70 beats per minute. Arterial pressure is 130/85. and body temperature is normal. Her pressure volume diagram of the left ventricle is shown. What is her cardiac output in milliliters per minute? Mariam, you were asking for the PV loops. Yes, it is the ventricular pressure, not the aortic pressure. The answer for this question, as you guys said, mashallah, it is indeed E. So, how did we solve this question? An important value to keep in mind, always, whenever you're solving, look for keywords in the question. Uh, Here, you've got 70 beats per minute. This is important. What did they ask us to calculate? Cardiac output. Tamam. So let me go to the next slide. Okay. Cardiac output. Cardiac output is heart rate multiplied by stroke volume. Now, how do you calculate the stroke volume? We need to, I forgot to explain this earlier, obviously. That's all. Let me explain it quickly. And diastolic volume and end systolic volume. Let's come back to this graph. Tamam. Now, end diastolic volume and end systolic volume. From the name, we're talking about volume. Tamam. So we don't need to focus with the pressure aspect of it, just the volume. Now, diastole, as you guys know, is relaxation. But at the end of relaxation, when the heart is relaxing and filling up with blood, the end volume that we get before the preload, this is the preload value, معلش. Before the contraction is known as the end diastolic volume. So when the blood is passively filling into the heart, this is end diastolic volume. The maximum amount of volume that we get at the end of diastole, right before the heart starts contracting again. And we're talking about ventricular diastole. And this involves point B, it comes after the atrial contraction. While end systolic volume is the amount of blood that's remaining in the heart after it's done contracting. تمام؟ يعني systole, the heart is contracting. And at the end, this is the volume that remains in the heart, 50. Now, 50, so that you don't get confused, because you're going to tell me, Abdullah, you mentioned in a point D, relaxation starts. So how come the volume that we're talking about is at point A? The volume at point D or point A is basically the same. Because remember, this is the phase of isovolumetric relaxation. But the volume over here, isovolumetric, same volume, is going to be the same. This is end systolic volume, or this is end systolic volume. It's just because we're looking at the x-axis. Tamam? That makes sense. So the way to calculate stroke volume would subtract the end diastolic volume from the end systolic volume. And it makes sense. Let's say, for example, we put 10 apples in a basket, and then I took 5 apples out of the basket. Or let's say I took 7 apples out of the basket. Tamam? The remaining apples in the basket are 3. But this way, when you calculate the stroke volume and diastolic volume, which is the maximum that we took, minus end systolic volume, what remained in the end, you get the amount that was pumped to the rest of the body. Make sense? That's the stroke volume. The way we calculate the cardiac output here is that we need to get the heart rate and multiply it by the stroke volume. The way we get the stroke volume, as we said, is end diastolic volume minus end systolic. So if you go back to this question right here, the end diastolic volume was 150, and the end systolic volume was 50. So 150 minus 50 is going to leave us with 100. So that's our stroke volume. As soon as we multiply it by 70, the answer is going to be 7,000. 70 times 100 is 7,000. Makes sense? Now, ejection fraction is another important factor that they might ask you about it. Just know how to calculate it. It's basically going to be the stroke volume divided by the end diastolic volume. And it's normally somewhere around 58 to 60. Okay, hemodynamics. We're going to take a quick break so that we could pray since we're halfway through the PAL. We'll come back and continue again. Tamam? Okay, guys, we're back now. Are you able to see my screen? Yes? No. Perfect. Okay. Someone was asking, Noor, will they always give us the graph? If it's for PV loops, then yes, they should always give you the graph, honestly. لأنه مثلا if they ask about, let's say, point A, what happens at point A, what happens at point B? you need the labeling on the graph to be able to answer it. But yes, inshallah, they will always be providing the graph for PV loops. Now, back to our lectures, hemodynamics. Now, Khalsa gave the PAL for hemodynamics, but I'm going to be disappointed if you guys are not able to answer these questions. So, mashallah, you already flooded the comments with answers. But that means you did a good job. طيب, let's read the question. Which of the following vessels has the greatest total cross-sectional area in the circulatory system? As you guys said, the answer is C. Simple question. Since capillaries have the highest cross-sectional area, they have the lowest velocity of blood flow because it's inversely proportional. Think of it like I'm asking you to fill a cup with juice vs me asking you to fill 100 cups with juice. If it's spreading around rather than going into one place, it's going to be going at a slower speed, and that makes sense. تمام. Now, this question. Let's see if Kharsa actually really did a good job, mashallah. The following illustration depicts a vascular bed consisting of vessels organized both in series and parallel. The resistance of each vessel, R1 to R5, is indicated. The pressure at point A is 80, and the pressure at point D is 31 millimeters per mercury. What is the flow through the system from point A to point D? We got a 7. Any other answers? We got a 10. Okay, so we have two different answers now. We got an 18, so that's three different answers. Okay, let's see what the answer is. Should we give you guys more time? About 10 more seconds. All right, so the answer is indeed B, 7. So, Abdullah, how do you approach this question? I wrote the explanation for it here. Basically, let's look at the keywords that we have in this question. تمام. The following كده. It's both in series and in parallel. تمام. The resistance is given, R1 to R5. The pressure at point A is 80, and the pressure at point B is 31. تمام. So we're supposed to calculate the flow, صح? And what's the formula for flow? You may ask. Let's see the next slide. The formula for flow is the difference in pressure over the resistance. So the first thing that we would do is calculate the pressure, since they gave it to us easily and directly. The pressure at point A is 80, and the pressure at point D is 31. But the difference in pressure between them is going to be 80 minus 31, that's 49. Now for the resistance, remember we've got the ones in series or the ones in parallel. Those who did O-level physics probably hated these words. Me too, صراحة. But let's look at it. So in series, whenever the resistors, the resistance is given in series, you add it directly. The resistance at this point between A and B is 3. The resistance at the point between C and D is 1. تمام? However, when it's given in parallel, you calculate it differently. And let's see what I did here. I did the resistance in parallel or in series. Now in series, as we said, you add it up directly. 3 plus 1 is going to give us 4. تمام? 3 plus 1 is going to give us 4. Now we need to calculate the remaining ones here for R2, R3, and R4. All of them are 9. تمام? And the formula is going to be the resistance in parallel. 1 over resistance is going to be these three values added up together. And 1 over R is going to be 1 over R2 plus 1 over R3 plus 1 over R4. So 1 over R3, R2, R3, R4 is going to equal 3 over 9. So 1 over R is equal to 3 over 9, cross multiplication. That means it's going to be 9 divided by 3, I believe. And that's going to give us the resistance of 3. But the total resistance here is 3, تمام? For the part in parallel. The part in series is 3 plus 1 directly, as we said, 4. So the total resistance, when you add them up, 4 plus 3 is going to give us 7. And then flow, if you go back to our formula, difference in P over R, which means it's 49 over the 7 that we calculated, The answer is 7, B. Those that were saying different answers. Does it all make sense now? We need to add R1, the parallel, and R5, the parallel. We do one. Yes, exactly as you said, Ibrahim. Okay, perfect. Let's move on to the next question. So, in a laboratory experiment, a blood vessel is perfused with saline at a constant flow rate. Keyword constant. Let me highlight it as we go. Use the annotation tool. At a constant flow rate. Hemodynamics is all basically physics, man. Thought I finally escaped. Anyways, the driving pressure along the vessel is 32 millimeters per mercury. After the application of a vasodilator, the vessel radius doubles. تمام. Assuming all the other hemodynamic parameters are constant, what new driving pressure is required to keep the flow rate constant? Now this question is, I would honestly say, a bit more advanced. It's more of an AJR style of question because he taught us last year. I'm not sure if Dr. Mooney would go to this extent, but let's see. Can you guys solve this one? Someone said A. Let's wait for more people to answer. Another 10 seconds. We got another A, mashallah. Oh, okay. So as you guys said, oops, one sec. Yes, as you guys said, indeed the answer is A. So the way to solve this question, it's honestly a bit confusing, so I'll need you to focus with me. This is the explanation from the book, and this is the way I calculated it. Tamam. This is the formula. It's Poseid's equation. I'm not sure how to pronounce his name, but I'm assuming French scientist. So what I want you to focus on in the question is that like what was given to us. They mentioned that we've got constant flow rate, تمام? So flow rate is going to remain constant throughout everything. Whatever we change, this flow rate is always going to be the same. That's the first thing that I did. I set it as C, a constant, تمام? After that, we were given the driving pressure of 32, and we were told that the vessel radius doubles, تمام? So again, driving pressure initially was 32, and the new radius is 2 times the original radius, تمام? Now, assuming all other hemodynamic parameters are constant, okay, what is the new driving pressure? So we need to calculate the new driving pressure. So they said all the other hemodynamic parameters are constant. But when we come to this equation, تمام, I want you guys to do this. All of this is constant. All of this is not going to change. So you could literally ignore it. تمام. Look at the equation this way. Flow rate, حتى this is constant then. So you could ignore it as well. Flow rate is equal to driving pressure to cube of the radius. تمام. Flow rate, again, let's look at the equation here. Flow rate, as we said, is a constant. Even after we applied the changes, even after the radius doubled, the flow rate still remained the same. So what is this supposed to mean? It's a simple multiplication rule, صح? Let's look here at this question. We said C, the flow rate, the constant, is equal to the initial driving pressure multiplied by R1 to the power of 4, okay? The C is constant. Hello? The radius, we said doubled. So in order for the C to remain the same, although the radius doubled, what should happen? The driving pressure should go down. That makes sense, صح? And this is exactly what I wrote here. And if the radius is going up, that means the driving pressure must go down in order for the flow rate to remain constant. Are you guys following until now? All clear? تمام. Now the radius, we said it doubled. But if you look at the equation here, the radius is to the power of 4. تمام. هنا I set it as 1. Let's assume إنه the radius was 1. Our new radius, we said it doubled, so R is now equal to 2. However, we're supposed to check the change in the cubic fold, if that makes sense. I know it's R to the power of 4. It's not just R. So whatever change we need to do, we'll multiply it by 2 and then take it to the power of 4. So the answer is 16. So that means the change in the radius resulted in the flow rate going up by a 16-fold. تمام? And the flow rate jumped up by 16. So what does this mean? That means that the driving pressure, the new driving pressure, must go down by 16 to oppose the change and keep the flow rate equal. That makes sense? So initially, our flow rate was what? It was 32. But now, since it changed by 16-fold in order to ensure the effect of the radius is negligible, we're going to divide 32 by 16 in order to get 2 as the answer. Does that make sense? All clear? Any questions? Can someone at least confirm in the chat if yes, it does make sense? Clear? Okay, thank you. And now let's move on to the next question. Also in dynamics. Oh, 1 second. Clear the drawings. Yeah, clear the drawings. Okay. In a capillary, PC is 30, PIF is -2, delta P is 25, and delta IF is 2. What is the direction of fluid movement and then a driving force? This is an easier question. This is probably something Dr. Mooney would get. Hussein is saying, why did we divide at the end? Okay. It's because multiplication and division. Okay. It makes sense. If the rate doubled, multiplied by 2, or 2 to the power of 4 is 16, which means it multiplied by 16, the other one must get divided by 16. Okay. Because multiply 16, divide 16, that's going to equal 1. It's going to remain the same. Make sense? I'm seeing a couple of these. Assalamu alaikum. So yeah, indeed the answer is D. And this is how it solves it. So when we're talking about osmotic movement, we've got 4 pressures or 4 factors that we need to keep in mind. There's the capillary pressure, the plasma colloid osmotic pressure, the interstitial fluid pressure, and the interstitial fluid colloid osmotic pressure. Okay. Now, this takes you guys back to foundation, if you remember, when we're talking about proteins and how the water would follow them and so on. So this is what plasma colloid osmotic pressure is. The capillary pressure is trying to push, and the capillary pressure is the volume, it's the fluid that's present. It's trying to push, it's pushing against the vessel, tamam? While the plasma colloid pressure is trying to bring the fluid back into the vessel, tamam? So these two forces are opposing each other. And that's how it is, okay? Hatta on this side, the colloid pressure is going to be attempting to bring the fluid outside. Yeah, this is how the colloid osmotic pressure works. It's always trying to bring the fluid to itself. But the capillary pressure or the interstitial fluid pressure is trying to push out or against itself. Tamam? So the way we would solve this question is that would add up the capillary pressure, would add up the forces that are moving in the same direction. So we should add up the capillary pressure PC along with the interstitial fluid pressure, which is pi IF, okay? So PC, which is 30, let me get out calculator. PC, we said is 30, and then pi IF, we said is 2. So that's 32, tamam? And then 32, we're going to subtract it from the plasma colloid osmotic pressure, which is pi P, along with PIF, which is the interstitial fluid pressure. So that means, remember, keep the 32 in mind. We're going to take said which two? The pi P, which is 25, and the PIF. Where's the PIF? Which is -2 here. Okay, so 25 plus -2, that's 23. If we subtract the forces that are pushing out against the ones that are coming in, we're going to get +9. تمام? +9 means since we subtracted this from this, it means that the force that's pushing outside is 9 times higher than the one that's trying to keep it in or bring it inside. So as a result, we've got filtration. فأنت after you calculate, you're left with B and D, and that's when you would go for D as the answer. All clear? If the answer was negative, it would be absorption. Yes, it depends how you do the calculation, but yes. And you just generally follow the same rule that I told you. If it comes up as positive, it should be filtration. Then when I subtracted the forces that are pushing outside against the one that's trying to bring it in. So when you do it that way, if you get a negative value, that means it is absorption. You are correct. Okay, of course. And then heart valves and sounds. This is again one of my favorite lectures. A 65-year-old patient presents to the emergency department with shortness of breath. She describes being fatigued and weak for months. Echocardiograph visualize a hollow diastolic murmur that can be auscultated at the upper right sternal border. Her arterial blood pressure is 154 over 63. That's high. Which of the following pathologies best explains these findings? A. MashaAllah. Okay, since you guys get it, we'll go through it quickly. No need to spend too much time. The answer is indeed A. So the way we figured it out, they mentioned it's a diastolic murmur. Tamam. So there's a mnemonic that I'll show it to you in a bit. But they mentioned it's a diastolic murmur, and they mentioned the upper right sternal border. Okay. Now, if you look here, the aortic area, when we're talking about the upper right sternal border, we're checking for the aortic valve. But that's why the issue is with the aortic valve. It's not any of the others. And why is it regurg, not stenosis? I'm gonna give you this little tip. Honestly, just remember this. As soon as you go to the exam, whenever you see a question, keep this mnemonic in mind. It was given to us by Dr. Simon last year, God bless him. Systolic murmur and diastolic murmur, تمام? ASMR. If it's a systolic murmur, then the cause is one of these two. It's either AS or MR. So what does ASMR mean, Abdullah? That isn't that like what people be doing on YouTube, eating food and with high quality mics and letting you enjoy the experience with them? That's how you could remember it, ASMR. But it stands for something. Aortic stenosis and mitral regurg. تمام? Aortic stenosis and mitral regurg. Uh, This is for systolic murmur. For diastolic murmur, you could honestly just memorize one of them. When you go to the exam, flip it for the other one. Diastolic murmur is ARMS. So here, the question mentioned, it's a hollow diastolic murmur, which means we're looking at ARMS. It's either aortic, regurg, or mitral stenosis. And the answer is indeed aortic regurg. So the reason why it's aortic regurg, I know they mentioned diastolic, but they mentioned that it's auscultated in this area. تمام? Second question. In which of the following disorders would left ventricular hypertrophy normally occur? E, C, we got an E, we got a C. Let's see what the answer is. The answer is indeed E. It's a simple recall question from your slides. Just remember that hypertrophy occurs with aortic stenosis, while, yes, left ventricular hypertrophy, while dilation occurs with aortic or mitral valve regurg. So how did I explain what stenosis and regurg are? Stenosis is basically when the valve is calcified, or just basically think of it as hardened, tamam? So if this door right here, tamam, I'm usually trying to push against it and it's normally opening. But if there's three people standing behind it pushing against me, I'm going to struggle. It's going to require from my side in order to be able to open the door. And that's basically what stenosis is. When the valve is hardened so that you would require more pressure in order to open it and fill the following area with blood. As a result, it causes something called concentric hypertrophy. In concentric hypertrophy, what happens is that the muscle mass itself increases. Yani we've got more muscles being recruited, or more muscles contributing to the contraction itself. So the size of the chamber decreases, but the muscles themselves, their number does not increase, معلش, but they increase in size. They become bigger in order to contract. Because cardiomyocytes, they do not increase in number. That's why when someone suffers from an AMI, it's replaced by fibrosed tissue. So no, the muscles themselves become bigger. Okay, they're hypertrophy. That's why they're able to contract stronger. While dilated is also a type of hypertrophy, but it's eccentric. What's happening is that the chamber itself is becoming bigger, تمام? Rather than what is it called? Rather than the muscles themselves becoming bigger. So as a result, you could hold in more blood. And why does this happen? What is regurgit? I could never pronounce this word for the life of me. Regurgit. المهم, whatever it is. What happens is that this is the exact opposite of stenosis, تمام? In stenosis, the valve was getting harder. it's becoming weaker. As a result, following contraction, let's say after the ventricle contracts and it enters into diastole, normally the aortic valve should close, صح? But in this case, the aortic valve, although it's closed, it's slightly weak. It cannot fully stop the blood that's trying to flow back into the ventricle. And as a result, the blood that's flowing uh, back into the ventricle, which originally wasn't taking place أصلا, starts happening. As a result, the end systolic volume increases, many other things happen. بس إنه المهم it results in this eccentric hypertrophy. تمام. Just keep in mind if the question mentions hypertrophied left ventricle, it's probably aortic stenosis. If it mentions dilated, then it's aortic or mitral valve regurgitation, whatever. So now control of cardiac output. Ahmed, can you take over?
So, hi again, guys. It's me. So, let's start with the first question with the control of cardiac output. Where is there a question? Okay, already answered, mashallah. A patient is brought to the emergency department after being struck by a truck. He is suffering from severe internal hemorrhage and rapid losing blood volume. Which of the following physiological responses is most likely occurring as an immediate compensation? So let's see what people answered. Okay. So the answer is actually B. Wait. Okay, this is yeah, it is B. Yeah, carotid baroreceptor firing decreases. Now, why does that happen? So let's analyze the question. A patient is brought into the emergency department after being struck by a truck, suffering from internal hemorrhage. Internal hemorrhage basically means internal bleeding. So bleeding, blood is going out from the vessels. With blood going out of the vessels, blood pressure decreases. Now, when the blood pressure decreases, there is less stretch on the baroreceptors right here. Okay, when there is less stretch, the firing rate decreases. Now, when the firing rate decreases, the brain says, okay, so we have less firing, we need to increase the sympathetic. So, but we could stop at the firing rate, but if the question asks for more details, we could say that it increases sympathetic or decreases parasympathetic. Okay, so the answer here is B. Let's say B. Yes, exactly, mashallah. Okay, so here's what I said. Basically, decrease in blood pressure will reduce the stretch of the carotid sinus, to therefore reduce the basal firing rate of baroreceptors. And if you want to continue, it will cause the brain to increase the sympathetic or decrease parasympathetic. So just to make sure that everyone understand this concept, because I guarantee that this concept will be asked on, because every year they ask about it, and it's very important, صراحة. So when baroreceptors are activated due to an increase in blood pressure, which of the following response occurs? So we said increase in blood pressure, so the stretch, so there is more stretch on the carotid sinus, so the firing increases, and if it increases, the brain says, okay, we have more firing, we need to decrease that. So how do we decrease it? Increase parasympathetic or decrease sympathetic. So let's look at choices. Inhibition of sympathetic, yes, perfect. Perfect, mashallah, exactly. So basically what I said again, increase in blood pressure cause an activation of baroreceptor reflex, which will increase the firing rate and inhibit the sympathetic slash activate the parasympathetic. So is this concept clear? Because you are guaranteed to ask, because the doctor emphasizes on it a lot. He spent like 30 minutes explaining it in the lecture. So okay, bismillah, let's move on. Shift cardiac output curve so there is a shift in cardiac output curve to the left. So in this moment that there is a shift, what is the effect? Okay, so okay, the question is worded wrong, Salaha. That's on me. Sorry, guys. But let's see exactly. So yes, it is exactly. So do you remember which one was the cardiac output curve? Was it the one that was increasing or was it one that decreasing? Yes, increasing. So yeah, so I actually got a question wrong about it because the question said cardiac output and I forgot which one was which, and I got it wrong. So make sure to not do the same mistake. So here's the curve exactly. So the causes of hypereffective heart, it increases heart rate, increases strength of contraction, which is basically hypertrophy. Okay. So there's in the increase of sympathetic stimulation, What will happen when the unstressed blood volume increases? So again, question tries to confuse you using weird wording, but all you need to know from the question is there is increase of sympathetic stimulation. My bad, guys. Nobody saw ما علينا. So what will happen when there is increased sympathetic stimulation to the venous curve? Okay, see, yes, mashallah, mashallah. Getting everything right, mashallah. So it is C. So here is the curve we're talking about, not the curve. So when I said when you say increase the mean systemic filling pressure, it's this right here. So it's down right here. So when there is increased, so as you can see here, when there is increased sympathetic stimulation right here, look how much there is filling. Moderate sympathetic, look how much there is filling compared to the normal, which is in the red, which is the almost 7. So yeah, that's basically it. So now it's back again for Abdullah.
You, Ahmed. Okay, so this is going to be our last lecture today, inshallah. Integrated control of the cardiovascular system. So let's start. A healthy 25-year-old male medical student has an exercise stress test at a local health club. Which of the following sets of physiological changes is most likely to occur in this man's skeletal muscles during exercise? Let's see, guys. Let the answers start rolling in. Someone said D, or this might be on the previous question. I'm not sure. So we got a D. We got another D. Got another D. You guys sure? Okay. Since we got three Ds, I think you guys should be confident with it. Well, the answer is not D. The answer is G. You guys flip it. No, it's up, up, down. Type. I'm going to show you how to approach this question. They mentioned that he's taking an exercise stress test. So it's basically when you're exercising. What is going to happen to these three following parameters? Arterial resistance, adenosine concentration, and vascular conductance. So when we're exercising, we're using up more oxygen, we're using up more nutrients. So how does the body respond to that? It's going to decrease the resistance in the arteriolar system so that the blood could flow more smoothly, and that makes sense. That's why the arteriolar resistance goes down. So that means A, B, C, D, all of them could be eliminated. We're focusing now on E, F, G, and H. تمام? After that, adenosine concentration. Now, what is adenosine? Dr. Mooney mentioned two important parameters that are responsible for the increase in blood flow. He mentioned that the first one, the increase in blood flow as a mean of compensation. He mentioned that the first one would be hypoxia or decrease in oxygen, and then the second one is metabolites. So adenosine comes from ATP, adenosine triphosphate. When it's being broken down in our body, when ATP is being used up in our body, it's broken down into adenosine. As a result, when we're exercising, the adenosine concentration is going to go up. For now, we're left with which options? We're talking about F and G. We could eliminate E and H. Now, F and G, the last thing is vascular conductance. So we're talking about the veins. What's going to happen in the veins? Conductance, compliance was its response to change. I think, if I'm not mistaken, conductance was its ability to allow the blood to flow back to the heart, as in venous return. So the vascular conductance is going to increase. That's why the answer is G. Does that make sense? All clear? Vasodilation of skeletal muscles, so resistance decrease. Vasodilation of skeletal muscles, so resistance decrease. Yeah, perfect. Because the blood is going to shift, the body is going to shift the blood flow to the active muscles. Second question. If a person has been exercising for 1 hour, which of the following organs will experience the smallest decrease in blood flow? This is a simple recall question. Assalamu alaikum. A, perfect. The answer is indeed A. And the reason is that the blood flows to the brain and to the heart, if I'm not mistaken. Yes, the brain and the coronary arteries is going to have a little effect. Because think about it, the brain is such an important organ in the body. It controls almost basically everything. So we need a specific amount of blood flow that's always going to the brain. whether you're exercising, whether you're asleep, whether you're at rest, the amount of blood that's going to the brain should always be consistent. تمام? It's one of the parameters that the body ensures is always happening. لأنه if you decrease blood flow to the brain, a person could collapse, or if we increase it, they could undergo a stroke, لا قدر الله. And that's why the blood flow to the brain and to the heart is tightly regulated. I think the renal system as well, if I'm not mistaken, but I don't see Dr. Mooney mentioning it here, so just stick to brain or coronaries, تمام? Next question. Which of the following is normally associated with the chronic stages of compensated heart failure, assuming that the patient is resting? We got two E's. Any other guesses? Any other answers? Fully confident answers, no guesses. MashaAllah alaikum. Well, yeah, the answer is indeed E. Uh, Dyspnea, no. Decreased right arterial pressure, it actually increases. Decreased heart rate, there's no reason for the heart rate to be decreased. Sweating is not really specific for compensated heart failure. At the chronic, we're saying. E is increased mean systemic filling resistance. It is indeed the answer. لأنه basically what happens is that when the patient goes into heart failure, لا قدر الله, the way the body compensates or tries to combat it is in two ways. The first one is that it increases the sympathetic tone in order to cause the vessels to vasoconstrict, increase the contractility of the heart, increase the heart rate. So this is done. This is the first thing that's done. The second thing that's also done is the RAS system. Now, Dr. Mooney mentioned in the recording that he's not going to stress over it too much, because you guys will take it later on again in renal. But simply what happens in the RAS system is that the amount of urine that's being produced goes down, or the fluid that's the amount of water that's rather than being saved and in retention is given out in the urine. What happens is that the body tends to retain this water retain these fluids. So as a result, the blood volume increases and goes up. And it increases these two factors, the increase in the sympathetic tone with the increase in the blood volume will result in an increased mean systemic filling pressure. Shouldn't it be increased, right? Right arterial pressure does increase, but here it says decreased right arterial pressure, not increased. I see it in chronic cases, the right arterial pressure is going up. This one says decrease. If it did say increase, then you're 100% absolutely right. All clear. I think this is the final question. Patient with right heart failure presents with shortness of breath. Tests to reveal right ventricular hypertrophy, a systolic murmur, and pitting leg edema. There's no indication of left ventricular failure. Which of the following hemodynamic changes is expected in the pulmonary capillaries? Remember, keyword is was it right heart failure? You gotta be okay. Well, the answer is actually A. And this is about the proteins, the interstitial colloid osmotic pressure. Thus, we're focusing on the pulmonary capillary hydrostatic pressure, the fluid itself. And we mentioned that there's right heart failure. So, what does right heart failure mean? The right ventricle is not contracting properly. So, the capillaries that take the blood supply to the, what is it called, to the lungs, the pulmonary capillaries, are not getting any blood flow, adequate blood flow. As a result, there's going to be decreased capillary hydrostatic fluid pressure rather than the proteins. Make sense? That's why the answer is A. And again, Dr. Moon is stressed on this. Keep it in mind. Most of the questions that I picked were stuff that he mentioned is important in the recording. And now for the general exam questions. Ahmed is going to go first.
السلام عليكم again. So, hope you enjoyed our all like deep explanation of each question with this lecture. Uh, we try to save as much time and explain as much as we can. And now for the general exam, we're gonna put up the question, you're gonna answer, and you are going to be the one to explain. Okay, so I'm not gonna explain, I think, for the next four questions, I think. So, Bismillah. During the ventricular myocyte action potential, the plateau phase is crucial for maintaining a prolonged depolarization that allows sufficient time for calcium entry, cardiac contraction. Efflux or influx of specific ions contributes to this phase. Efflux of which of the following ions contributes most to maintaining the plateau in ventricular myocyte action potential? So let's look at the answers. A, C, C, A, C, A. Okay. So whoever said A, you fell for the trap. Why is it C? Can anybody who answers C explain why? Calcium influx and potassium. Exactly, exactly. You got it exactly at the point. Calcium influx and potassium efflux. As you can see here, it's efflux of which of the following ions. So read the questions carefully, guys, in the exam, because they can trick you and probably will trick you. Try to trick you at least. Especially Dr. Paul. He likes to play with the little words to change the meaning. Okay. So for the next question, what type of block is this? Let's see the answers. B, B, B. MashaAllah, MashaAllah. كله B. MashaAllah. Okay. So it is B. So can anybody explain, please? Long PR, long PR. Perfect, guys. MashaAllah, MashaAllah. But if there was a prolonged PR gradually with a drop, which answer would it be? Morbid type 1, Morbid type 1. Yeah, exactly. MashaAllah, MashaAllah. You guys studied well. Okay, so next question. Which of the following combinations favors the development of re-entry arrhythmias? So let's check out the chat. Take your time with this question, by the way, because mm, B, 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 B. MashaAllah. Yeah, exactly B. Can anybody explain why? So with these type of questions, Salah, before anyone explains, with these type of questions where you got like tables or like more than one category to answer in, just start with the ruling out. This thing favors the combination of re-entry. So you gotta have, is it short conduction or long conduction? You gotta have it long conduction. Why? So you give space for the depolarization to happen again. I mean, you should not give space normally, but we're saying favoring arrhythmias. So it's gonna be long conduction. So we can rule out A and C. So let's continue with B and D. So is it fast conduction or slow conduction? It's actually slow because we're trying to the goal of going as low as possible for each myocyte and between each myocytes, each two myocytes. Okay. So again here, long refractory period or short refractory period is gonna be short refractory period because as we said, because refractory period is a time where no depolarization can happen. Okay. So does everyone understand this? Is everything clear? Clear. Okay. MashaAllah. Perfect. So if there's a parallel left shift of the venous return curve, which is true? Remember, which one is the venous return, and which one is the cardiac output? Be careful. Can you explain it again, please? The one before. Okay. So, what do we mean by development of re-entry arrhythmias? What's re-entry arrhythmias? So basically, a myocyte where it's gonna have a depolarization again before like the whole heart relaxes. Okay. So how does it favor that? So we know that there is a refractory period, or like there is a short, there's more than one factor that stops this from happening. But we want to go opposite for from these factors. So long conduction pathway would be one of those factors. Slow conduction and a short refractory period. Okay, so there's a difference between pathway and slow conduction, by the way, so you gotta be careful with that. So I hope you did understand. Please tell me if you didn't. I will read them again. Did you understand it? All right, guys, thanks. Okay, perfect. You're welcome. Okay, so again to this question, which is true? There's a parallel left shift. Hmm. Any answers? Not a single answer so far. It's a short question. See? Okay. Anybody else? Any other answers? C. Okay. Well, it's not C. It's actually A. Because C. It's A. Yes, exactly. It is A. So remember. Um. Okay. Let's go back to the graph for it's no like this. This, yes, this. Okay, so this one, the tall one, is the cardiac output, and this is the venous one. So when I said the parallel left shift will cause a decrease. But I said that if a left shift happened to the cardiac output, it would be an increase. Okay, so you gotta be careful because I did this exact same mistake. Is it this one? Yes. Okay. Can they both be right? Oh, wait. Okay. استنى شوي. Use Venus Saturn. Okay. This is okay. No. C is not wrong. So this is my bad, guys. I'm not sure why did I put it like that, but yeah, C is also correct. Both of them are both of them are correct. So this was my bad, guys, again. But yeah, decrease Venus return is also correct because it's a left shift and it will what cause decrease. Yes, you guys are right. So I'm sorry, guys, if I confuse you, but you are right. Yeah. So, and is any of these four questions unclear, or is there anything that you did not understand from my questions in general? Anything? All clear? Okay, perfect. Okay, so now it's Abdullah again. Well, before I give Abdullah the mic, I want to give you a couple of tips. When you answer a question, you're kind of lost. Make sure to rule out like start ruling out and cancel out the answers. Another thing would be with especially with cardiophysiology, connect the lectures with each other. So you saw a question about baroreflex, you saw a question about the graph. They could actually connect them with each other, and they did that last year. So make sure to have complete focus and focus on keywords. Okay, keywords. Like this is short. It's the short question. To there isn't anything specific like to rule out. But for example, this question, like you can just read this sentence and know what the question wants. Okay, so keep those in mind. Inshallah, you'll do good. And yeah, I'll give Allah again.
Righty. The final time today. Let's see. Our first question. During exercise, TPR decreases because of the effect of we've got sympathetic nervous system, splenic arterioles, parasympathetic nervous system, skeletal muscle arterioles, local metabolites on skeletal muscle arterioles, local metabolites on cerebral arterioles, and histamine on skeletal muscle arterioles. You guys give me the answer. Couple of C's and an A. Ibrahim, are you sure about that A? You said during exercise. Remember, we're exercising, want to increase the blood flow. And the T power is decreasing. There's decreasing resistance. The answer is indeed C, as most of you guys said. We mentioned it earlier. The first reason to increase the blood flow would be ischemia. The second one is the metabolites such as adenosine, potassium, and so on. There's a couple of examples that Dr. Mooney had in his slides. Now, sympathetic nervous system, that would be constricting. It's not going to decrease the resistance. That would increase it. Parasympathetic nervous system on skeletal muscle arterioles. For instance, this might throw you off. When I say, طب Abdullah, parasympathetic is relaxation, why not? As we don't have parasympathetic acting on skeletal muscle. That's not the case. Then local metabolites on cerebral arterioles. Remember, we mentioned the brain is tightly regulated, but there isn't that much change in resistance when it comes to the brain. Then histamine. Histamine has to do with immunity, inflammation, has nothing to do with skeletal muscle. Ibrahim said, I don't know. Don't worry about it. It's fine. MashaAllah, you've been answering correctly a lot during the session. Next question. This is an example of what Ahmed was talking about, the integrating of multiple lectures together. Let's see if this question is going to get you guys. Well, we taught you well. There's a B. Got a B so far. 55-year-old man presents with complaints of dizziness and shortness of breath on exertion, and even is trying to do something, physical activity. The physician detects a heart murmur heard during the portion of the cardiac cycle labeled X on the image. Which of the following heart valve pathologies would most likely produce this murmur? We got a couple of B's, B. Yep, perfect. MashaAllah alaikum, guys. So, how do we approach this question? They mentioned إنه كده. They mentioned a heart murmur that's heard during the part labeled X. So what is the part labeled X? Can someone tell me? Look at it. We've got higher atrial pressure than ventricular. So AV valves are open. What is happening here? Ventricular filling. Ya salam alaikum, mashallah. So that means diastole. That means it's a diastolic murmur, صح? Remember our mnemonic? Arms. So it would be aortic regurg or mitral stenosis. So that's why the answer is B. Oh, by the way, keep this in mind. This is something that Dr. Simon would low-key do, but I don't know if Dr. Mooney would be this evil. But since this is a cardiac graph, where they're talking about the left ventricle, left atrium, the answer is mitral valve. The ASMR rule for systolic and arms for diastolic also applies to the right side of the heart. We're talking about tricuspid valve and pulmonic valves. So Dr. Simon would low-key be the type of person to put this question and mention the murmur is on the right side. I expect you to answer and say this one is mitral valve stenosis. They expect you to say tricuspid valve rather than mitral. If I'm not mistaken, that was an SAQ for us last year. I did not pick it up. I ended up losing half a mark because I flipped. I said mitral instead of tricuspid. But make sure you focus on the question well. Tamam? Next question. In the hemodynamic pressure tracing below, rapid ventricular filling begins at which point of the figure below? This is also a simple question, inshallah. We got D. Yes, perfect. Assalamu alaikum, mashallah. So D, again, the atrial pressure is exceeding the ventricular pressure. As soon as that happens, the AV valve is going to open and blood is flowing into the ventricles. Next question. A 23-year-old healthy woman runs 2 miles at a moderate pace. Based on the, I don't know what changes that occur while running, which left ventricular PV volume, pressure volume loop most likely represents this woman's status during her run. The dash is normal, or the full one is, what is it called? The changes during exercise. We got a B. Well, yes, the answer is indeed B, mashallah. لأنه we said, remember, this is end diastolic volume, this is end systolic volume. So the bigger the difference in the graph, the higher the stroke volume. Remember the apples in a basket example that we mentioned? The higher the difference is, that means we're pumping more blood. That makes sense. During exercise, we're trying to pump more blood, supply more muscles, and so on. Next, which of the following events is associated with the first heart sound? This is our last question for today. We got an E, an E, an E, an E, and another E. Perfect, mashallah alaikum. So the first heart sound is closure of the AV valve. What about the second heart sound? The dub. That would be a closure of the semilunar. Yes, sir. اللي هم aortic و pulmonary. And that's basically it from our side today. Thank you so much for joining us in today's session. Please scan this QR code for feedback, especially since it's my first and Ahmed's first class session. We'd love to hear feedback from you guys in order to improve for future times, بإذن. Well, best of luck with your exam. You guys got this, inshallah. Ahmed, would you like to say anything?
Other than the feedback, actually, there are some extra questions on the QR code. So make sure to solve those. And if you have any concerns with those questions, feel free to contact us or to contact us any concern you have about cardiology physio. Thank you.
Our first year in general. We'd love to help بإذن. Well, best of luck, inshallah.